In this video segment, we'll discuss the second part of the esophagus and esophagitis. So esophagitis can be caused by lacerations, chemical injuries, infection, reflux, as in the case of Barrett's, or eosinophilic esophagitis. So the first thing we'll discuss is Mallory-Weiss tears. So this is the most common type of esophageal laceration. It's going to occur in bulimics or people with acute alcohol intoxication, and this is because it's due to prolonged vomiting. So just repeated vomiting is going to cause these long linear tears within the esophagus, and as a result, patients will present with hematemesis. So on endoscopy, again, you see long linear lacerations. These tend to be superficial. However, Mallory-Weiss tears can lead to Boerhaave syndrome. And Boerhaave syndrome you can think of as boring a hole in your esophagus. So this is when the tear becomes transmural and the patient's going to have mediastinitis. So you'll hear a crunching sound upon auscultation of the heart due to that pneumomediastinum. Okay, so chemical esophagitis is caused by acids or alkalis, alcohol, hot fluids, or even smoking. Clinically, the patient's going to present with a self-limited odynophagia or pain with swallowing. And if it's severe enough, you can get hemorrhage, stricture, or even perforation. Of note is that you can also have a pill-induced esophagitis, and this tends to occur with really large pills such as the HIV antiretroviral medications. In infectious esophagitis, this will typically occur in immunosuppressed patients from HSV or CMV. You can also have fungal esophagitis, which is typically due to Candida infection. So fungal esophagitis, again, Candida is the most common organism involved, but Aspergilla and Mucor species can also give you esophagitis. And this can be due to a primary infection or a complication of a pre-existing ulcer. So on endoscopy with Candida in particular, you're going to see this adherent gray-white pseudomembrane. And on biopsy, you just see all the yeast forms there. Okay, so viral esophagitis, we like to compare herpes esophagitis to CMV esophagitis. Herpes, you're going to get these punched out ulcers, whereas in CMV, the ulcers tend to be a bit shallower, but they're also well demarcated. For herpes, on histology, you'll see both nuclear viral inclusions. You'll just see the nuclear viral inclusions in the epithelial cells around the ulcer edge, whereas in CMV, you get both the nuclear and cytoplasmic inclusions, and these are going to be in the capillary endothelial and stromal cells. So CMV likes the endothelial cells, herpes likes the epithelial cells. And in these pictures, you can just see the different viral inclusions. So eosinophilic esophagitis can have different presentations based on age. So adults are going to present with food impaction and dysphagia, whereas kids will present with feeding intolerance and GERD-like symptoms. Typically, these patients will initially be treated with a PPI because of GERD-like presentation. However, because that's not what's causing it, you're going to get failure of the PPI treatment. Eosinophilic esophagitis is also associated with atopic dermatitis, allergic rhinitis, and asthma. So on biopsy, you're just going to see a marked number of eosinophils in the epithelium. You can get up to 100 in there, and the eosinophils are going to extend into the upper esophagus, and that's one way you can differentiate this from GERD on biopsy, because with GERD you will see increased eosinophils, normally not to the same amount. However, in GERD it is also restricted to the lower esophagus. So treatment for eosinophilic esophagitis is just going to be dietary restrictions and corticosteroids. Okay, so reflux esophagitis, or GERD, gastroesophageal reflux disease. This is the most common cause of esophagitis and typically occurs in those over 40. In terms of the pathogenesis, it's due to decreased lower esophageal sphincter tone or increased abdominal pressure, which allows reflux of gastric juices into the lower esophagus. So things that cause decreased LAS tone and or increased abdominal pressure will result in GERD. This includes alcohol, tobacco, obesity, CNS depressants, pregnancy, hiatal hernias, or delayed gastric emptying. So grossly, the esophagus is going to be hyperemic. And on histology, as we kind of talked about earlier, you will see eosinophils in the mucosa, but less so than in eosinophilic esophagitis, and they're restricted to the lower portion. In addition, you'll also see this basal zone hyperplasia, where the basal layer takes up more than 20% of the total epithelial thickness. You also get elongation of the lamina propria papillae, and the amount of damage that you see is often related to the chronicity of the disease. So patients will present with primarily heartburn, difficulty swallowing, they can get regurgitation with a sour taste, and a very common presentation is actually just a prolonged cough. So a cough that's just been going on for a long time. More severe complications can include ulceration with hematemesis or melena, and you can also get formation of strictures or Barrett's, which is intestinal metaplasia of the esophagus. So treatment's going to be with a PPI. So Barrett's esophagus, as we just said, is intestinal metaplasia within the esophageal squamous mucosa, and it's a complication of long-standing GERD. It occurs in 10% of patients with GERD. Typically, it's more common in white and males and those aged 40 to 60 years of age. So your patient's going to have a history of GERD. And of note is that patients with Barrett's are at increased risk of esophageal adenocarcinoma. So it kind of follows this progression where you start with a GERD, then you get metaplasia, and eventually you'll get dysplasia and adenocarcinoma. So Barrett's on endoscopy, you'll see these salmon tongues as pictured here in the center. And that's just red velvety mucosa extending up from the GE junction, alternating with the residual smooth pale esophageal mucosa proximally and the light brown gastric mucosa distally. So again, on histology, you're going to have intestinal metaplasia where you're seeing these columnar epithelium with goblet cells replacing the normal squamous epithelium. So on the left is that normal squamous epithelium, and on the right here you can see it being replaced by intestinal metaplasia, intestinal columnar cells with goblet cells. Note, you can also have dysplasia, either low grade or high grade, or carcinoma, where you're getting invasion into the lamina propria. So you have to be very careful in reviewing the slides. Okay, so hiatal hernias are when you get separation of the diaphragmatic crura and protrusion of the stomach into the thorax, and these can be congenital or acquired. Typically, patients are asymptomatic.